This is so I just wanted to let you know in the past, these have gone really well. Just feel comfortable interrupting if something comes up, something you're experiencing, questions about anatomy. Our approach towards this, because every person we treat, and I know Ali would agree, has their own unique symptoms, own unique experiences. So what we're going to do today, and I'll go over it in lecture, happy to provide this lecture for you as well, is basically go over the nuts and bolts of pelvic floor, talk about estrogen and symptoms that you may be experiencing, and then some things we can do for them. So please feel free to interrupt at any time. And I'll give us more formal introductions, Ali, in the lecture for you all, so you know more of our educational background. But I'll let Ali do an introduction of herself, and she's also brilliant, and we're both happy to answer as we go along.
Hey everyone, thanks for joining. Just to kind of reiterate what Holly said, I'm Allie. I know it says Rachel, so it's confusing, but can ignore that part. And yeah, I've been working with N2 for about 6 years, so it does feel like a long time, but it also is just a little pebble in a ripple of water. And just have learned so much both from Holly and my own personal experiences treating patients. So if you are comfortable sharing what's going on with you or asking questions about that, we're happy to answer that if you want to wait till the Q&A portion as well. And then as things come up in during the lecture, there's a lot that's like, even if it doesn't necessarily relate to you, but you're like, wait, please dive into that. Don't hesitate because that's what we love to do.
We do. We love talking about pelvic floor. Um, Patrice, it will not let me share right now. Are you able to fix that? There you are.
I think you're muted, Patrice.
Yeah.
I'm sorry about that. Yes, you
No,
should
no
be able
worries.
to.
Okay, I'm on it. Okay, so here we go. And I cannot, oh, now I can see you. So if you wave or raise your hand, Allie will chime in or I will, and we will get rolling with this. So this is essentially giving you pelvic health foundations, and we'll get into a little bit more about what that means. But what Ali said is exactly right. This is going to trigger a lot of different things for you, experiences you might be having. And if you are comfortable at some point, please do chime in. So, what to expect from this? We would love to get some camaraderie, meet other people ambitious to understand more about your pelvic floors, gain some familiarity with your pelvic floor and how it connects to the rest of the body. Before you all signed in, Patrice and I were talking about how this is not widely known and it plays such an impact in everything that we do and is linked to things like headaches, foot pain, jaw pain, in addition to some of the more intimate problems that we experience. We will just talk about potential symptoms that come up, potential vulvar, especially dermatoses to monitor and request screening. Allie and I could tell you stories for hours about how we see women who have gone years not knowing that the burning they experience in their vulva is something we can treat, not knowing how common it is to get lichen sclerosus and how treatable that is. So we want you to know about this and feel very comfortable self-screening. We are going to talk a little bit about estrogen changes. This comes up in our clinic with our clients a lot and how this relates to pelvic health and what some newer research is saying about estrogen supplementation. And then we're going to go over some very basic self-care and home techniques. And I give everybody who attends these classes my emails. N2 Physical Therapy has an app now that we can send you exercises through and education through, and we will give you those resources at the end. Again, interrupt at any time. So I think I've got Allie Pomerantz here. This is our more professional introduction. She's a doctor of physical therapy, board certified women's specialist, center coordinator for N2 of Clinical Excellence. She has taught tons of students her expertise. What Allie is brilliant at, in addition to that, is she's also been a certified yoga, fitness, strength instructor, and we both share a passion for empowering women, empowering survivorship to get as strong as you can in ways that are fun and maybe not encouraged at all times, such as strong lifting. Heidi is on the right in our main N2 office. We call her our chief emotional support dog, and Allie is also Heidi's human, so I needed to include her. Our patients love Heidi. My background, I am also a doctor of physical therapy. I carry an MBA. I have a CLT, which is Certified Lymphatic Therapy from Norton School of Lymphedema. Lymphedema is a wonderful topic if you want to bring that up because the treatment for that has changed. It's incredibly treatable, and a lot of myths about it have been debunked, fortunately, over the years. I'm a certified myofascial trigger point therapist and applied functional science fellow, and also have my WCS with Allie. So we love this. We've seen a lot. So I hope at some point you feel comfortable if you want to interject and ask any questions. So, what is pelvic health? At N2, we want to define this as being empowered through education and growing confidence and knowing what your pelvic floor is, because pelvic health comes first with education and the ability to talk about it. So, more importantly, it's understanding how the pelvic floor does interact with the rest of your body. And I think, and I bet Ali is going to start nodding, that's what gets missed a lot. We get a lot of people who have this chronic back pain, chronic hip pain that they treated for years, and it was part of the pelvic floor. Or vice versa, people who've had urinary leakage during exercise and maybe the pelvic floor structure was healthy, but it wasn't interacting properly with our abdominal system. So it is a big picture in our bodies that sadly we do not learn about until something's not going right. And then having good pelvic health means you have a meaningful understanding of the pelvic floor. And when I say that, I want to encourage you that meaningful is individual to you. It's not what somebody on social media says you should be, the internet says that you should be. It's what is meaningful to you. So this picture is a hot mess of nerves and muscles, but I love it because here's pelvic floor way down here. I don't know if you all can see my arrow or not towards the bottom, but you can see how this is really interwoven in our bodies with the hip muscles over here, the lateral hip muscles, the QL, and the spine. So there is much more to pelvic floor than just being urine, bowel, sex, and we will talk a lot about that today. So, sex education, unfortunately, didn't include the pelvic floor, and quite frankly, still doesn't. And that's one of Allie's and my secondary missions is to teach teenagers. So we grow up knowing this. But many women have never heard of their pelvic floor, even if you've delivered babies, had pelvic surgeries, been to gynecology, and treated a gynecological cancer. So pelvic floor also, I love this picture, this meme. It is also not just Kegel exercises. And I do think there is amazing intent in medical communities to say, oh, do your Kegels and that will help. But it is significantly more complex from this, and we will get into that. And I encourage whatever questions come up about this. So, what does the pelvic floor do? So, lecture speaking, science speaking, it's involved in urine and bladder, bowel, posture, sexual activity. Life speaking, functional speaking, it's everything on the left. But pelvic floor can be part of what we like to call bladder chatter. People who feel like they have to go all the time, or they always have a sensation of like burning in their bladder, or needing to evacuate urine. It's part of breathing. It's definitely a part of movement, exercise, weightlifting, restoring the core. It's part of sitting still, standing still, obviously intimacy and pleasure. And it's also supportive of our organs and other structures for our body. Um, and then what does your pelvic floor look like? And we will have a ton of pictures about this. It attaches, it's sitting, all of us are sitting. So you're sitting on your pelvic floor and you can feel your hip bones. Can you guys still see this? Sorry, I thought I heard someone. And it attaches from right to left via an internal hip muscle called the obturator internus. And Allie can also vouch for this from all her years of experience. That hip muscle causes a tremendous amount of back pain, bladder pain, abdominal pain, pain with sex. It's kind of a nuisance in our body when it's not happy. The pelvic floor attaches front to back. So if you feel your front pubic bone and then think about or feel your tailbone, that direction as well. If you are contracting your pelvic floor, it is not your bicep muscle, but it's similar to the muscle shortens and brings the pelvic floor upward towards your head. And when you release it, it goes downward back towards the seat that we're sitting in. If you are lengthening it or trying to open so you can release bowel, release bladder, get some relaxation out of it because it's causing pain, you're actually using a diaphragmatic breath to help facilitate that pressure drop down and it's lengthening. One thing I want to point out is, and Allie, would you agree? I think this is sort of how PT has evolved and how they teach it. A Valsalva, like when you're weightlifting or you're pushing really hard to use the restroom or pushing in general, trying to get anything to release from pelvic floor is not a proper relaxation or a proper lengthening and actually is counterproductive and asks the pelvic floor to contract. And the reason I would say that's important is because when people are experiencing abdominal pain, constipation, difficulty with leaking, difficulty with emptying their bladder, it's a very natural kind of mental reflex to think if you just push hard, it will help. And that technique makes it worse. And we will talk a little bit more about that as well. Everybody doing good so far? I can't see anyone. Good? Okay.
Mhm.
Any questions so far?
Are we going to get a copy of this?
Yeah, absolutely.
Okay.
And you know, Patrice, I'm gonna send you, I every time I come back and check on you, I lose the presentation. Sorry.
No
I'm gonna
worries.
send you an updated PDF because I even after I sent this to you, I did some updates. So, but yeah, I'm happy to give you all a
Yes, so everybody, I'll send around the video version of this as well as the presentation
Thank you.
um, once
there.
we get it.
Yeah, absolutely. So here's the muscle. Allie and I always joke you do not need to memorize the names of these muscles, but neuroscience in our field really supports like kind of putting a face to a name, helps our brains just recognize them. So I always go over this very nerdy scientific anatomical naming. So what you have here in the middle, I think is easiest to identify is you've got the urethral opening, the vaginal opening, and then down here the rectal opening. And this muscle that looks circular around it is called our bulbospongiosis. Some texts call it bulbocavernosus. Either way, if you are experiencing pain with sex, that muscle is typically a culprit. Here along this bony landmark, you have ischiocavernosus, and it goes on both sides, sort of like an inverted, or it is actually like the top of a triangle here. And then across here, you have what's called superficial transverse perineal muscles. These muscles have a role in the continence of urine, releasing urine, support all of the things we're talking about. These two here, ischiocavernosus and bulbocavernosus, are frequently cited as the most important as far as sexual function. And I think if you visualize it and can kind of picture it, you can see how if that muscle's tight, if our skin over it is de-estrogenized, it's going to make penetration painful. Here you have the external anal sphincter, and then of course that's the anus where bowel evacuates. Go to the next one. Huh. Sorry, you all, I'm having trouble with this. Hmm. Let me see. Hmm. I'm gonna try. I'm still owner, right, Patrice? I'm gonna try resharing.
Yeah, you should
That's
still
really weird. It
be.
just kind of kicked me out. That's
You
okay.
know what? When I left, let me make you co-host again and
Okay,
see.
awesome.
I apologize, you guys.
Look,
I have been responsible for the technical issues today, which we are going to remedy.
let me see. There we go. There we go. Okay. So perineum explained. Perineum, if you think about your sits bones that you feel when you sit, especially when you sit for too long, the perineum is this triangle of muscles here at the top. If you take this model and divide it in half, what's really cool about this muscle is it is equal right to left. That doesn't mean that something on the right is exactly the same as something on the left. Sometimes when people have babies, experience tearing, have surgeries, or even just overuse injuries, it will change, and that is okay. Just to reiterate, the muscle names are ischiocavernosus, bulbocavernosus, and then superficial transverse perineal muscle. And you have your urethral opening, and then you've got your vaginal opening. Internal pelvic floor muscles are more what, when you Google pelvic floor and they say levator ani, they are referring to. But I like everybody to keep an open mind that the pelvic floor is more than just those muscles and it's the bigger picture. So these muscles are going to attach from, if you feel at the front, the pubic bone to the coccyx, tailbone again. They do attach side to side to our hips and they have many functions. I can argue that they are involved in anything we do. There's even dental research out there that talks about how jaw pain, headaches are related to pelvic floor pain. So, because it is the center of our body, and unlike a bicep where you injure it and you can just give it a break, it's active all the time. It plays a role in things that we would have never really imagined. So, inside the pelvic floor, what you have here is it's like our whole body is cut in half. And here it starts with the lumbar spine, goes into the sacrum and the tailbone. And it's showing you this picture from the side that I really like because a lot of people experience hip pain with pelvic problems. So you can see here, you have our hip bone, the femur, and this is where an internal hip muscle lives and creates an attachment point for pelvic floor. And then you can see here how it just broadens outward and has its relationship moving upward in the piriformis and the low back. So I like this picture to help try to give a visual of how this is related to the rest of the body, especially from a pain and an intra-abdominal pressure perspective. For a direct view, here is your levator ani. So here you have the pubococcygeus, puborectalis, iliococcygeus, and the coccygeus. And again, you do not have to remember these crazy names, but I'd like you to meet your pelvic floor scientifically. This is where, with treatment of cancer of all kinds, especially gynecological, I want there to be an understanding of the very different causes of burning in the vulva, pain with sex, discharges that might come up, discomforts in general, maybe it's more itching. So this is just a surface anatomy look at the perineum. You do not need to memorize all this, but here you have the labia majora. Here you can see the vaginal orifice, and this is where we would label it as mucosa, labia minora. And when Allie and I do exams for people from a PT perspective, a musculoskeletal perspective, we do check this area for any changes in the skin, any changes in the tissue health, because it is very common. So I'm sure some of you have experienced symptoms like that, and there is absolutely help and ways to self-check this. So just to sort of break it down, healthy perineum anatomy, when you think about what you're experiencing as cancer survivor working towards survivorship and before, think, did you have any symptoms that you had prior? Do you have symptoms now that are different? Do you notice differences in how it feels walking around? Sometimes people will tell Allie and me it feels like something's just rearranged, feels like swelling, it feels like more friction. All of those things are valuable information. Are you feeling itching? Are you feeling burning? And then I do always want to talk about shaming. We were talking before this even started. This doesn't come up in conversation, and we would love for people to feel like they can talk about this. And there's changes in our environment, perceptions, and this is absolutely something that happens, and it's okay to talk about and ask questions about. What you're looking for, and what we tell people, especially if we're doing like telehealths and we don't get to see people in person, is take a mirror and look, and you're looking for healthy pink tissues. Does your vulvar area or even your anal area feel differently when you wipe? And we'll talk a little bit more about that. Does it hurt now to wear underwear, pants, yoga pants? Is something different there? Do you have specific points of tenderness? If you were to reach down, say you're in the shower and just like manage to palpate in regions that are tender, does it hurt? Do you have any lacerations? And a laceration would be if you see redness. We have had patients see some bleeding or some light blood in their underwear, and then is there a discharge? So these are all things to be aware of and to check for and feel confident in checking for on yourself and talking about. Just sort of a review on the roles of estrogen. Estrogen promote increased vaginal pH. They have high concentrations in what is called the trigone of the bladder, and that gives them a secondary role in a UTI. So I will explain all the science in better terms. There is a little triangle at the base of our bladder that's job is to feel pressure of urine and give us a mental and brain signal that we have to go. Estrogen helps that do its job. So when we go through life, when we go through types of treatment that change estrogen levels, it's easy to start losing that signal and experiencing more frequency, more urgency, and more leaking. And that's where estrogen plays a role that's not always talked about. Estrogen is also part of our healthy biome. It supports detrusor function. And detrusor function, the bladder itself has a muscle of its own inside its wall called the detrusor. And it's meant to act like a healthy partner to the pelvic floor. When the detrusor muscle, the bladder muscle, is doing its job right, it senses when the bladder's full, contracts, sends a signal to the pelvic floor to hold on like voluntarily, but then relax. When people go through certain types of changes in life, treatments, menopause, estrogen changes, that relationship can sort of become dysfunctional. And then the detrusor either doesn't contract, it contracts too much, leading to urgency, and it doesn't keep that signal healthy. It also supports urethral function via urethral receptors, and that's why sometimes if people are eligible for estrogen cream, that really helps symptoms of urinary incontinence and even pain. So that's just a quick, minor, small overview on the roles of estrogen as it relates to pelvic health. So, just to kind of get it out there, symptoms that might manifest based on changes in estrogen would be pain and discomfort, such as dryness, burning, irritation. There's also labia minora fusing, and that means the labia minora might look smaller. We've had patients where you don't see it at all. That is all treatable. Lifestyle changes might come forward with this, bladder changes, urinary, potential predisposure to infection that wasn't there before, vascular changes. And then I'm going to talk about this because the statistics around this being out there as information are sad. This is called GSM, genitourinary syndrome of menopause. GSM, and this can be enhanced or exacerbated by different treatments for gynecological cancers. It can be provoked by it. So it's important to know about. But I want to kind of quote this study. There was an article called Vaginal Estrogen, What a Urologist Should Know, and they did a survey of 1,000 women in menopause with vaginal discomfort. What they found is the result of that was 58% of these women were avoiding intimacy, 30% were not having sex at all, 29% had sleep disturbances, and 27% just had general decreased life enjoyment. So these symptoms are important, they are damaging, and they are prevalent. Here's the flip of this. Of these women that were in this cohort, only 13% of them reported that their provider initiated a conversation about this. Of that small amount, only 9% received a diagnosis. And of that small amount, only 38% received a prescription to help. So Allie and I, as physical therapists, really experience being the first people to refer back to this, to send people back to their doctors to talk about this. But I like to include this in my public health lectures as well because it will help everything if we talk about this and we promote advocacy amongst ourselves too. So this is just a slide a little bit about menopause before and after so that it sort of helps you visualize that these changes in the skin do happen. They are treatable. I'm not going to get too much into this, but in a nutshell, you can see here on the left, premenopausal, you have a thick vaginal epithelium, thick layer of mucus, higher estrogen levels, and so forth. And this just shows how it breaks down. So this is a systematic review. This is a very personal decision. When I work with women who have treated any type of cancer, I bring this information forward and encourage a conversation with family, with trusted physicians, and I provide the article. So if you would like this article, I'm happy to give it to you. But they have shown that vaginal estrogen in the research does not show a risk of anything venous thromboembolism, that it's not associated with the risk of increased risk of vascular disease. The Women's Health Initiative is also being highly kind of attacked for not being a good study. So there's all kinds of confusing information out there for the public. It's also currently debated in a 2023 systematic review that vaginal estrogen in the mortality of breast cancer does not increase it. So, in a nutshell, if you need resources for this is something that you are going through yourself, I can provide those resources and we can certainly discuss it on email. Last but not least, we want everybody to know what lichen sclerosis is. This is one of those diagnoses that isn't well known. We frequently see it when people are treating cancer diagnoses. It has an autoimmune side to it, and that's likely why, but it is something that needs medical attention. It goes beyond itching and burning, and if you did a skin check on yourself, you would see more very red redness. Like it looks like it's bleeding, but it's not. You would see whitish tissue. What this is a benign inflammatory immune mediated skin disease that affects the genital area. Its prevalence per the research is low. Allie and I are biased because we see this a lot, given that this is all that we do, and we also see it go misdiagnosed frequently. So we want to empower people to know what it is because it's very treatable. But when it's active, it's very frustrating and even scary for people. So lichen sclerosis is something I want to make sure everybody knows. The symptoms of this are vulvar itching. That's the most common. It can be mild, it can be incredibly intense. It can be in that perineum area I just showed you, but it can also travel back as far as the rectal area. Sometimes there can be fissures. Those things are not normal. They can be treated, and that's when there's slight little, maybe just like pin drops of blood that occur with intercourse. Any kind of insertion, maybe after a pap smear or any sort of like penetration. There's also potential dysuria, which is pain with urination or pain with defecation. And you can sort of picture that because this is a breakdown of those mucosal tissues around the vaginal opening. When it's not treated, it can lead to progressive symptoms and vulvar atrophy. It can lead to progressive scarring and loss of elasticity. So it is important to know about this. Allie and I wouldn't say it's common on the grand scale like the research reports, but in our pelvic world, we see it more than people would think. So those are the symptoms to be mindful of, and you're always welcome to shoot myself or even Allie an email if you want to ask more questions about that. Vulvodynia is different. I would say vulvodynia is very common. And what this simply is just vulvar discomfort, whether it's burning, stinging pain, and it's associated with allodynia or hyperalgesia, which is essentially means like pain where it should not be, or a larger amount of pain for the cause of the pain. We do not need to get in the subsets, but I included them on there so you can read further. Vulvodynia is common. If you had this before treatment, it's possible that treatment or procedures and surgeries make this worse. This can be caused by tight muscles, overuse. This can be very much a musculoskeletal problem, getting misdiagnosed and mistreated as something else. So, Allie and I treat a lot of this, and it can be helped, and there are tons of tools at home. So, any questions here that we've gone through all the science before we jump into more like what you can do to self-assess at home and anything about resources? Everybody's good?
Thanks, Holly. I think it's probably a lot for
It's a
most of
lot.
us,
Yeah.
because I've never even had an anatomy course before.
Yeah.
So it's very insightful just even to see how complex the pelvic floor is. I
Yeah.
feel like that in itself is educational for us.
Good. Well, and don't feel bad that it's a lot because I'm sure Allie can chime in, but it was a lot to add this specialty as a physical therapist. Like the amount of studying and extra certifications and courses we've done. And I think it feels like so much as well because we never learn about this, even
Right.
been pregnant or delivered babies. So I think it's probably a lot and it's definitely scientific, but hopefully the slides will help and it just sort of starts to get the ball rolling on what's going on for us in that area. So now we'll get into more the practical application. So, oh, it's doing it again. I feel like every time I come back to see you all, I need to reshare. Here we go.
Sorry, I don't know what's up with that.
It could be me. Who knows?
Um,
Let me unshare and reshare again. Does anybody have any questions so far while we redo this? Okay. There we go. Okay, so and Allie, please feel free to add to these. I'm gonna keep it so I don't see you all because when I come back to you, it disconnects me. But these are pelvic health folk tales. These are urban legends of the pelvic floor. And boy, they are out there, especially if you're on social media. My mom lives in rural Nebraska, and I think she believes all of these. So, leaking is normal if you get older. This is false. Leaking is normal if you have children. Not true. Sex will always be painful because you had children. Sex is painful if you're older. Surgery is the only option. If you have a prolapse or other problems, a rectocele means your rectum's falling out. Constipation has been my new way for several years. It's never going to get better. If I stop drinking water, I won't leak anymore. If I do Kegels, it will cure leaking urine. If I do Kegels, it will cure my overactive bladder. This list goes on and on and on. This is the basic list. And when you layer in the various treatments for gynecological cancer, I think some of these folk tales grow further. So, the point of all of this is the internet has a lot of mis and disinformation, and these are folk tales. It can be helped. So, bladder and urine, these are responsible. Bladder holds back and releases urine. Pelvic muscles, as you can see, and even the connections to the hip can mimic overactive bladder and or urgency. Allie and I have countless patients where it started as hip pain. Maybe they had a treatment for cancer, delivered a baby that activated a pelvic floor problem, but the hip was the cause of the urgency and it looked like pelvic floor. So it's important to know that they can all manifest with each other. There are various types of incontinence. I listed them here: stress overflow, postural functional urge. I would say the most common ones that you all maybe are experiencing would be stress, where if you cough or you sneeze or you're exercising, and urge, where you get a stronger than normal signal to go to the bathroom and can't make it without a leak. Types of increased urinary or bladder activity would be overactive bladder, urinary frequency, and then there's another one called painful bladder syndrome. It used to be called interstitial cystitis, and its rename was because it encompasses so much. It can be all of the above things. It can be pain, it can be burning. So it's appropriate to refer to it as such because it really varies for everybody. These are also bladder folk tales. I just leak because I'm older. I'm just going to stop drinking water. I hear that one a lot. I go just in case so I don't leak. I have a strong bladder because I can hold it for 8 hours. I've always had to get up at night to pee. It won't change. So these are folk tales. Various types of treatments, medications, and procedures can add a layer of complexity to that. But even then, it doesn't mean that things have to stay a certain way or can improve. And we just throw this in here because one of the biggest things with treatments of a variety of cancers is the bladder, or not the bladder, sorry, the bowel issues, constipations, abdominal pain, abdominal swelling. And that also can be helped and can be treated. So when your pelvic floor might be involved in symptoms, if you're having any leaking or a hard time wiping clean when you have a bowel movement, when you have constipation with pushing or straining, bleeding with the bowel movement, pain with the bowel movement, hemorrhoid exacerbation, or even just insidious improvement in it, not being able to completely empty from bowel or bladder perspective, burning and itching in the vulvar region, feelings of infection, a new unexplained discharge, hip pain, back pain, ankle pain, jaw pain. You can see how this goes with the rest of the body. And then, absolutely, with sexual problems, pain with sex, pain with intimacy, um, anything related to that. This is a great resource. I don't know if you all have heard about this. These are kind of old school pictures of squatty potties. If you type squatty potty into Amazon, there's all kinds of versions of this. And Allie and I have even found little ones that will fit in like a tote or a purse for people who go into the office to work and need help with constipation. So, posture and pelvic floor, and this is another thing to just start thinking about on an everyday basis, it's incredibly related. And our core should be viewed as a system, and we call it the anticipatory core. And I'm just quickly going to show you how this relates. So, this is the side of someone's body. Here you have the spine. This is the multifidi. Here's transverse abdominis, which is an abdominal muscle, diaphragm, and pelvic floor. And you can see how if we had both sides of the body together, these need to be highly coordinated and work as almost a cylinder with each other. And that's where sometimes when symptoms of the pelvic floor come up, such as urgency, leaking, and we start to just chronically tense and hold, that's where this whole system, including the back, abdomen, breathing, can break down a little bit. I am going to just bypass this one. It's just a picture to show you how complex the nerves are. Probably the most familiar to you all over here is the sciatic nerve if you've ever had hip pain, but this is important to the pelvic floor. The pudendal nerve is important in sex and sensation, and it's very broad and has a tortuous route through the pelvic floor. So sometimes when people have pain with sitting, it's more than just the muscles, it's more than the mucosa, because you can see from this picture here that that nerve sprawls everywhere. So just something to be aware of. So everybody always asks us this, how do you do a pelvic floor exercise or a Kegel? Allie and I like to call them pelvic floor exercises. Kegel was named after Dr. Kegel, and I think everybody's trying to stray away from that. But think a little bit about what you've been told. If you want to share, you can. What does it feel like when you do a Kegel? Do you need to do a sit up with a Kegel? The bottom line is first, if you're experiencing pain, urgency, you have pain in your hip or your back, sometimes doing a pelvic floor exercise is asking an already tight contracted muscle to tighten further. So I would encourage everybody to get better idea of where is your pelvic floor at. And if you want to do, I call them baby Kegels, really tiny Kegels, not for full strength. You can envision just in the sitting position, pulling your pubic bone and tailbone together and just lifting your pelvic floor away from the seat. So here you can sort of see, here's pelvic floor, and when you squeeze, it's going to go up, and when you release, it's going to go down. When you print this, this is a great resource for pelvic floors out of Australia. This is going to talk to you more about the breathing part when the pelvic floor lifts and the deep abdominals draw in, and there's no change in breathing because you're just breathing easily. When you're holding your breath, that would be if you're like pushing or straining to really evacuate. You can see here that it creates an intra-abdominal pressure problem and pushes everything down. So read before squeezing. If you have any sensations of anything falling out, if you have increased pelvic floor pressure, if you're leaking urine or you have burning in your bladder or your urethra, if you are experiencing pain with sex, with medical examinations in the hip, the back, the groin, if you urinate and your stream sprays, slows down, or is shy to start, or you have constipation, think twice before just jumping into a Kegel program. And Allie and I have talked to so many people, and I think the intent behind this is fantastic that receive a sheet that says, here's how you do your Kegels. But if you have these issues, it means you might have a tight pelvic floor, trigger points in your pelvic floor, or pain. And it's important to get that like that pelvic health restored before you jump in and do a ton of Kegels, or you could make it worse. So if you answered yes, proceed with caution. If you all email me or get on our app, we love the pelvic drop. Some people call it a reverse Kegel, and that is safe to start and also gives strengthening through a different type of motion and helps you open your muscles. Your hips being tight. Oh, what's that?
Mama, I had to come in.
Is there a question? Okay, I'm going to keep going, but stop me if somebody needs to talk. So I'm going to fly through this because you're going to get these pictures, but these are good pictures to teach you how to self-check your hips to see if there's any pain involved there. So how these slides will work for you is what I'm going to give you more of versus talking through them is this is how you find this muscle that's highlighted in the green. And basically, this is going to walk you through where to feel if that hip muscle is a problem. That's the glute minimus. You're going to start with slow pressure. If you have no discomfort, that's probably not a problem. If it starts to feel uncomfortable, it might be a contributor. And you can reach out to get a pelvic exam, to get hip stretches, and know that you maybe need to get the whole system working together before you start doing Kegels. So what these slides will do will show you the muscles. And I will make this a PDF with 2 slides per page, Patrice, so that it's bigger and you can see. And
Great.
it'll teach you kind of just screen those out. So Allie should really be teaching from here on out because I think she's the local Denver fitness yoga expert and weight training. But muscle health before strengthening. Would you agree with that, Allie? Like,
Yes.
restore your normal habits, do trigger point release, do stretching, do internal muscle release. There are so many different devices out now than when I started this 16 years ago to help you learn how to release your muscles at home and do that safely. You could use a foam roller for your hips if you like that. And you can even just do very basic stretching routines that can be tailored for what your symptoms are, what surgeries or treatments that you are experiencing or have experienced that have had lasting side effects. These are also some home treatments. This is a Theracane. I know it looks like a torture device, but it's really good for getting into those hip muscles without having too much strain on your upper body. On the right is one version of countless versions out there of dilator sets. What you do with these is you take these, you put a ton of lube on it, and you insert them vaginally so they can help stretch the muscle. This set goes from small to large pretty quickly. There are sets out there. Intimate Rose is a really nice set. Hope and Her, and I can send you these sites, is a really nice set that have a little bit more of a progression than that. So there are all kinds of options, and these are wonderful tools to also help with your learning the pelvic floor exercises because when you squeeze, you'll feel it pull in. When you release, and you can practice releasing over and over, you can feel it drop out. So I highly recommend these for anybody having pelvic symptoms needing a home routine. These are some relaxation techniques and poses. We can send you these through our app. So diaphragmatic breathing is fantastic. Happy baby, a seated piriformis stretch, which is one of our deep butt muscles, a self-external release of the perineum muscles. We have a beautiful handout for that. It provides tons of pain relief for people who have vulvar pain and vulvar discomfort, even lichen sclerosis, because it helps bring the blood flow back. And then if you don't have a prolapse or knee pain and you can do a deep squat, that's also helpful. And then, of course, prayer stretch. So this is a great instruction for you. If you want this, the app that we have will send you a video of this, but the proper technique for a diaphragmatic breath, if you walk away mastering anything from this lecture, this will help. So I just tell people what you want to do is place one hand on your chest, the other on your belly over your belly button. This is best done laying down, but you can certainly practice it right now sitting. And when you take a deep, slow breath in, you want to feel your belly get bigger and rise to the ceiling while your chest doesn't move at all. And when you master that technique through intra-abdominal pressure control and our anticipatory core, your pelvic floor will naturally start to relax. And when we have women who have been through so much from a pelvic floor front and are just now getting help after years and years of these habits that we don't want, just restoring without us even knowing because we can't see it, this will be the best start at getting relaxation. And I think a good challenge, but I'll let Ali chime in, is try to make that inhale last 5 seconds and then the exhale last 5 seconds. But certainly, if that's too hard, and I find that that's hard for me if I'm experiencing abdominal pain or even heightened levels of stress, start with 3 seconds. But this would be a wonderful thing to start to learn. And it's sort of the staple if you're having issues with bowel, bladder, and sexual pain. These are some fantastic resources for you. This will come in your lecture, but that has a lot of the pictures on here, a lot of the descriptions of how the pelvic floor works with the core. Our app is a good resource. And I will make sure I give you my email, but if you get on this app, let me know and I'll make sure we just send you sort of some of our basics. There's also apps for bathroom tracking. The one that I think is best now is Plop. It also includes urinary and diet now, I believe. So if you need to figure out, are you having habits that maybe could be corrected and help you, that's a good place. I love this Headspace app for meditation and sleep. That app has 974,000 five-star reviews. It's fantastic. And then there's also an app for pain called Curable. So there are resources out there for this that you can get started on right away. And I think if you, Allie, do you know if Curable costs money now?
We can give 6 weeks free as
That's
providers,
what I
and
thought.
then it does cost money after that. I'm not actually sure off the top of my head what the cost is, though.
I'm not either, but if you want to try curable and we can grant that to you, I think you can get through a lot of it in those 6 weeks and then make
Yeah.
a really informed decision if it's working for you. So this is the wrap up. We have some time for questions, but I hope and I know this is a lot, but that you have a new pelvic floor muscle knowledge, that this, more importantly than anything, gives you more confidence to advocate for issues if you have them or bring them up and speak about them. And then understanding how to best care and start to care for your pelvic floor, including those self skin checks. I think that would help a lot of women and would have helped a lot of women. Allie and I have worked with to do that, and then understanding best bowel and bladder routines and also how sex weaves into this because sex and intimacy are so important to a lot of people and is absolutely a part of pelvic health. So I'm gonna go off screen for good and let you all ask any questions that you have.
Okay, thanks. I'm going to go ahead and end the recording right now so that we can go into Q&A.